Hello, I'm Manoj Karmakar. Welcome to ISSPS TV. In this next presentation, Dr. Georg Feigl from the Witten University in Germany is going to discuss with us functional anatomy of the lumbar paravertebral region and sacral spine. If you like any of our videos, do remember to like and share with your friends. Also, do remember to subscribe so that you can get regular notifications of any future uploads. Now enjoy the upcoming video.
Here we go. Okay, functional anatomy about the lumbar paravertebral and sacral spine. There will be a lot of images. Anyway, we have to put now a little bit the focus on the orientation itself, where you can start. You see, of course, the 12 spinous process of the 12 vertebra, thoracic vertebra. Then you get the suprailiac posterior spine, which is corresponding to the level of the S1 sacral vertebra. Then, which is the most important, the Taphias line or Jacobi's line, which is the most cranial point of the iliac crest. And then if you put together the two thumbs, you have over here the so-called spinous process of L4 level. Anyway, we put a short investigation about that in our dissection lab, where we really had the cadaveric position concerning that, and we took the most cranial part of the iliac crest and managed to insert at the cadavers, about the bodies donated to science, a pin into the spinous process, what we palpated. And then afterwards we dissected and just took a look where our pins were inserted to. And as you can see, we had the problems that in the female cadavers, we were partially not in the same level as we wanted to be. For example, L4, but sometimes we were at L3 and sometimes at L5. You can see this might be caused also because of the fat tissue, which is really a little bit of problem concerning orientation and palpation at level of the lumbar spine. Nevertheless, you get over here the palpation of the spinal processes and also, of course, of the iliac crest itself, 12 VPS, and the sacral hiatus, which is a very important area to insert the needle for a caudal anesthesia. Anyway, you have to be aware that now that the lumbar spine is changing quite a lot compared, for example, to the thoracic spine. You get the lordosis again to the cervical spine, same, but you have well-palpable spinous processes with a very huge vertical extension, which means about 2 centimeters or even more. This means that you have a long palpational part, and therefore you might be concerning, for example, insertion of needles in the wrong level. The large bodies do not concern us, but if we take now a very close look for the topography of the extensions of body and cervical the spinous process, and also the costal process and articular processes, you see that there are really some difference to be talked about. First, you get over here the vertebral body of the lumbar spine, lumbar vertebra. Then you have this costal process, which is again a remnant of a rib. Then you get the spinous process, which is a little bit more caudal than the vertebra of the same, the body of the same vertebra. And you get the articular processes, which are more or less in the sagittal plane now. So this is changing quite impressively. And you can see now the surface of the bony structures, which are causing now a so-called two-step anatomy. This means the spinous process is the most impressive peak going dorsally and superficially. Then you have the first step, which is the lamina, and also then a huge bulge going dorsally, which is the articular process or the zygoapophyseal joint, which can be seen partially. And then you have over here the costal process, which is the second step, more in the deep, and a very important landmark concerning its periosteum. Of course, you get ligamentous parts, which are important that there are barriers or walls in between different spaces. You get the supraspinal ligament with the interspinal ligament, which can be visible quite easily by ultrasound. And then in the next, you see in the deep, of course, the flaval ligament, which is partially missing in the median sagittal plane, caused by the different development of this ligament itself. So you see this ligament over here, and then a very important ligament which is in between the costal processes, and this is something what you can see. It's not really a wrong terminology, because it's called intertransversal ligament, but as this is a remnant of a rib, it should be intercostal ligament. But anyway, you see, this is a little bit a strange terminology. But who cares about names? Very important, this is visible. And the barrier for the space dorsally to it, where you will find the erector spinae muscle, and ventrally, where you can find the psoas muscle and also the quadratus lumborum. Nevertheless, again, you will have also degenerative processes and also some other images of scoliosis, and these might change your anatomy entirely, not in the ventral part, but in the dorsal part. You also get some troubles concerning missing fusions, as you can see, like a spina bifida. And this is something that also have to be kept in mind, especially in the sacral bone, because of the fusion which is coming from cranial. It might be missing caudally, as you see it over here, where you have no fusions at all, no continuing crest or crest which is running through. As I already told you, also some other degenerative processes. If you make a closer look over here on the zygoapophyseal joint, it is covered by this osteophyte. So you might not see the gap or the capsule, because the capsule is over here entirely ossified and covering this place. Already quite well visible. This would be very painful in this area. And if you get something like this, of course, you might face some troubles concerning the orientation of the surface. So you have to really turn the probe to get a real good image, because you do not only have a scoliosis, but also a torsion of the entire lumbar spine. And of course, you cannot deny over here help, but you have to try to get the best image out of it. Concerning the sacrum, you find this hiatus sacralis, a sacral hiatus, which is flanked by the two horns of the crests, which are terminating over here, and then it's covered by a membrane, which is the sacrococcygeal membrane, which is well visible then, as you will see it later on. And again, now this important area where you see the sagittal direction of the zygoapophyseal joint, and also here some not osteophytes, but these are also changing a little bit the course. Anyway, you see over here then small mammillary processes and accessorial processes. These two, for example, these are the so-called degenerated transverse process. And in between, you find a small groove where the medial branch will pass by and turn around and will send either to the cranial and caudal zygoapophyseal joint the nerve fibers. Nevertheless, you get a muscular coverage. Again, you have different layers where you get the superficial fascia or lamina of the thoracolumbar fascia. Then you get over here the latissimus dorsi, as you can see it over here, this is the first layer. If you put away the muscular part of the latissimus dorsi, you see the serratus posterior inferior muscle. In atlases, it's a huge muscle, also drawn. If you have, for example, very aged cadavers, you might find only some small fibers, muscular fibers, but they are still visible in ultrasound. If you keep on going, you find the third layer, which is the erector spinae muscle, and then you have to put all the nerve fibers away, like the longissimus and the iliocostarum, and you find then the zygapophyseal joints. This is the dorsal view of the lumbar spine with the lamina, with the spinous processes, and then over here you see the zygapophyseal joints opened. And now the medial branches turning around and running medially in this area. And what you can see over here, you see the nerve fibers really quite well, because we cut away the ligament, which is fixing this nerve in its position in between the mammalar process and the accessory process. And in the caudal part, you see still the ligament extended in between these two small bony processes, which is fixing this nerve, and the nerve has to pass underneath. And this is now the point where it reaches the area in between the two zygapophyseal joints, and then we're giving up the fibers to the cranial and also the caudal segment of this zygapophyseal joint. So a very important place, a very important area where you can insert the needle in between the articular process and the costal process, where you have these two small parts. If they are visible, just position the needle in between, and then you have a very good spread. Unfortunately, if you just say, okay, I just go on the lamina, you might have some troubles because of the intermuscular injections, and it might not spread medially. So really stay in this area, try to get as close as possible to this base of the costal process, just close relation to the articular process, and you will be on the safe place to get the medial branch. Whereas the lateral branch, you can see the lateral branch over here, originating from the dorsal branch, which is piercing over here a small foramen in between the intercostal or intertransversal ligament and muscle. Then you can see over here, this is the lumbar aponeurosis, which is in between. And if you just insert the needle or advance the needle more ventrally, you will reach the psoas compartment. Anyway, also be aware that there are some vessels just around, as you can see on the dissection itself. So just if you go more ventrally, if you go more close to the dorsal branch, you have to be aware, of course, of some bleedings or muscular structures. Let's take a look now on the cross sections. You can see the spinous process with the supraspinal ligament. Then in this area, the thoracolumbar fascia, which is the superficial part. Then you can see the deep part, which is the lumbar aponeurosis. You see then the erector spinous muscle, and then really no distinct clarification of the different muscle fibers, because this is a network which is more or less a three-dimensional network composing of different systems of the erector spinous. You see also the zygapophyseal joint, and then the area where you have the nerve, the medial nerve branch passing by and turning around. Also over here, same, you see the cross section, you see this thoracolumbar fascia with the costal process over here, running not very that transverse, but more oblique dorsally, and the area of your spinal medial branch would be just over here, where you can see this is the area of the articular process, the base of the costal process, and this is the area where you find the medial branch turning around. So if you take the ultrasound, It's a very old ultrasound device what we had in Graz. I will be lucky and happy to have a new device next year in Witten. But you can see if you take an old one, it's still visible, these 3 steps, where you get the spinous process and then the articular processes, which are forming the sacropaphyseal joint, and the costal process in the 3rd step. So where would be now the medial branch, in this case over here, so you can insert the needle to this flank where you find this branch. Is it visible? Unfortunately not. So this is one of the problems, that you really have to go on with the device, and you can see, for example, the medial branch passing by over here, and on the other side would be also on the same place. Concerning another image, what you can see, if you just go a little bit more medial lateral from the spinous process, you find a small gap in between, where you can reach afterwards the ligaments, the flaval ligament and the dura, which is quite well visible for any well advancing to, or the advances to the spinal canal. And if you go even more laterally, you just have the surfaces of the costal processes, and in between, if you advance the needle over here, you might reach, or you get into the psoas compartment. So this is something you have to be aware of, especially if the visibility is a little bit changed. Let's go to the sacral bone now. At the very last part, you see over here just a nice distinct cranial position of the hiatus, or extension of the hiatus. If you advance over here the needle too far, you might risk to reach, for example, the dural sac and also the subarachnoidal space. You always have to be aware of different verifications. Let's make a short cross section over here, that you can see the thoracolumbar fascia is very distinct, thick. You have only in well, older people not very much left of the erector spinous muscle, but anyway, you can see now the gap of the so-called sacroiliacal joint, where the joint is more ventrally, and dorsally you find the ligament, which is the interosseous sacroiliacal ligament extended over here. And you will see only with your ultrasound device more or less the superficial part of it, and then underneath just, well, imaginable that there is a gap in between. Is something visible over here too. You might see this, well, more or less triangular shaped structure, and then you know that you can insert the needle in this groove where you have all the nerve fibers passing by and inject over there. This is something what you can see also in the ultrasound. You see also the gap in between, and also partially really the dorsal foramen. If you get more cranially, you see the entire dorsal surface of the iliac bone, sacral bone. And this is something where I can also put the needle easily, because the nerve fibers will pass by, and going laterally to the sacroiliac joint capsule innervation. If you go more dorsally, cranially, you see again, there is a small gap in between where you can insert the needle. I talked about the sacral hiatus, where you see again this more cranial extension, partially quite well visible. Anyway, you still got your horns, which are flanking the hiatus, and also the membrane, of course, and then you can insert the needle over here. This is visible by, for example, this cross section where you have the gluteus maximus muscle. Then you have the horns. This is enlarged over here. You see now the horns, then the sacral canal and the membrane, which is covering the entire area, and therefore it's quite easily to insert the needle over here. And if you make then an ultrasound image with an even very old ultrasound device, you see the two horns and the membrane quite easily to insert the needle underneath. So also again, a lot of different images, cross sections, a lot of anatomy where you have to be aware of not to get in the wrong areas. And that we hope that skiing season will start this year and not be canceled because of the still ongoing pandemic. We're looking forward that there also will be some practice for any clinician that you can deal with it, also with pain therapy, and you can see it over here. And therefore, thank you for your kind attention.
Thank you, George. That was a nice and crisp talk, and I'm sure the participants have enjoyed it. So, Brian, can we get on to the panelists on board, onto the display? Yes, I can see CP, but he's not part of it. Yeah, Christine. Okay, what about Shankar and George? So Dr. Christine Loy is one of the consultants in our department. She's helping us with trying to filter out some of the questions, if there may be. So Christine, are there any questions addressed to any of the speakers?
I don't think there is any questions addressing any of the speakers yet.
Hey, what kind of attendance are you guys? You know, I'm sure you have many questions to ask. I see a lot of you typing them out. Why don't you put them up in the Q&A? Anyway, George and Shankar, if you are still around.
Yes, we are.
Yeah, George is here. Shankar, where are you? Okay, I need you to please turn your video on, please, Shankar. Okay, George, here I have a question for you.
Okay.
This is maybe a little bit unrelated, related, but you're a clinical anatomist. So I am going to put forward a very practical question, which is kind of based on some of the buzzwords that are moving around today. Now, when you look at the lumbar spine and the thoracic spine, you have a superior costotransverse ligament in the thoracic region, which is in the intertransverse plane. It is attached between the neck of the ribs and to the lower border of the transverse process. It has two slips. I also read that the superior costotransverse ligament is non-existent at the transition zone, which is like T11, 12. So I like to hear your comments on that, one. Two is, what replaces the superior costotransverse ligament in the lumbar region at the intertransverse plane?
Okay, first of all, the changing is absolutely really dramatic in the area what you suggested or just mentioned. That's correct, but that's easy to explain. You get the frontal position of the sacrophysial joint areas in the thoracic part, and then it has to change to a sagittal plane, which means you get a more or less shift of the planes in the sacrophysial joint. And therefore, it's also a change of these processes. So you get over here at T11 and T12 already the sagittally, especially in the T12 section, the sagittally positioned vertebra, and therefore a change of these processes to a more or less, degeneration of the transverse process and then the costal process, which is more or less then developed. So the costotransversal ligament is lost. This is something which is important, and it's changing to this mammilloaccessorial ligament. And therefore, the position of the medial branch is also changing, because it's not like in the thoracic spine, you get this constant course in the groove and in between the sacrophysial joints, but more or less a little bit more lateral course. And this is something what we dissected, and we will publish hopefully next year. It was dissected by a student who, this was his thesis, and he dissected, I think, more than 25 spines in all the different areas. So this, especially the area of T12, T10 to T12. So the course is changing, and also, unfortunately, a little bit different to the thoracic spine and also the lumbar spine itself. So because of the adaptation of the position of the articular processes.
Thank you, George.
Just a moment. Second, is there what about the costotransversal ligament in the lumbar spine, as you asked as a second question? You get the membrane in between, so this is lost. The ligament does not exist. And therefore you get a huge gap, which means you might be in the area of the dorsal branch, which is piercing this foramen. You get a better flow ventrally. But nevertheless, if you really want to reach the lumbar plexus, for example, you have to advance the needle much more. You cannot go with a huge spread ventrally if you just say, okay, I want to be dorsal to this membrane, to the intertransversal ligament.